I'd like to invite Dr. Teresa Carmen to the stage and have her talk about VTE prevention in the medically ill. Is there a role for direct oral anticoagulants?
All right. Thank you, and I'd like to thank the organizers for the opportunity to be here. I don't really have any disclosures, but I will say that at Case Medical Center, we were a participant in the APEX trial, which I am going to discuss. So here's the dilemma in our medical patients. We know that medical patients are at risk for venous thromboembolism. That risk is relatively low if you look at most of the data. It's about 1% of patients. The problem is there are a lot of medical admissions. One study recently published in more of a select population, that risk may be as high as 5%. Most of this, not most, but many of this, about 25%, occurs after the patient goes home. So it's not in-hospital VTE, but it's VTE once they've left the hospital. Further complicating this is the fact that our medical patients are very heterogeneous. So it's unlike our orthopedic population, where it's a very homogeneous population, and when we give them prophylaxis, I think we have more confidence. In the medical population, it's very heterogeneous with respect to their reasons for admission and their overall risk factors. On the other side of the coin, we know extended prophylaxis works. It works in our orthopedic population. It's a mainstay of patients with abdominal malignancy and undergoing surgery, and now even more so in bariatrics. But again, these are more homogeneous populations. So what do we know about venous thromboembolism and risk in our medical patients? The higher the number of risk factors, the increased risk of venous thromboembolism overall. And the trial on the right is a trial out of Australia. This is where they found a 5% risk of venous thromboembolism in their medical population. And as you can see, that risk was much higher with an odds ratio of almost 6 in their patients with a history of previous venous thromboembolism. It was not a pure medical population because the odds ratio in patients who had surgery within the previous 30 days was five-fold increased. And again, pulmonary patients and their oncology patients, you can see much higher. So we've had trials that have looked at extending prophylaxis and trying to capture this patient population, particularly in the DOACs. So the ADOPT trial that looked at enoxaparin compared to extended dose of apixaban, 2.5 milligrams twice a day, and then we had the Magellan trial that looked at enoxaparin compared to rivaroxaban, 10 milligrams for an extended duration up to 35 days after admission. And the venous thromboembolism in the ADOPT trial, not statistically different between the two groups, but there was a higher risk of major bleeding, and that became a bit of a concern. In the Magellan trial, there was a risk reduction of venous thromboembolism, again, but at a cost of an increased risk of bleeding. So when you look at the meta-analysis on the right-hand side of the slide, certainly short-term efficacy, long-term efficacy did favor the use of the 10As in these populations, but they both came at a cost, and that cost was the increased risk of bleeding. So the APEX trial was recently published and looked at enoxaparin compared to betrixaban, which is another 10A agent. The patients were highly selected patients for having an increased risk of a hospital-acquired event, and they were further risk stratified even to a higher risk using age and D-dimer. Their composite outcome was asymptomatic DVT, symptomatic venous thromboembolism, as well as venous thromboembolism-related death. You can see in the primary efficacy outcome that betrixaban was favored and was superior compared to the enoxaparin. Symptomatic venous thromboembolism also lower risk in the betrixaban group compared to enoxaparin, and the major bleeding was not really significantly different. There was a statistical increase again in major or clinically relevant non-major bleeding. What has come out of the betrixaban trial is a number of different publications looking at subgroups, and some of this is really quite interesting. So the slide on the left-hand side of the slide is a reduction of ischemic stroke in patients with heart failure or ischemic stroke at the time of entry into the trial. So these patients seem to really have a significant risk reduction in a secondary event of ischemic stroke. The other thing that came out of this trial that I thought was most interesting is in patients with a prior history of venous thromboembolism, they also seem to really benefit from this extended prophylaxis event. This is a bivariate analysis that was recently published, and you can see it looks at ESCLAIM, which is an older trial that looked at extended low molecular weight heparin therapy, ADOPT, Magellan, and APEX, and if you put those all on the scale, you can see on the left-hand side there, really the ADOPT trial does fall into that favorable category for a lower risk of bleeding as well as improved outcomes. So should we be thinking about this? Well, I'm going to say probably. If we can find the right group, it's probably going to be cost effective. But I don't think we can apply this broadly across all medical admissions and think that it's going to be the right way to go. I think we probably need better screening tools than what we have for our medically ill patients. I think if it's used appropriately with good upfront screening, we can assure access, and then we can follow up and get some secondary data on efficacy in the real world. It indeed may be a future going forward. Thank you.